Good evening all. Today we will discuss about artificial airways in ICU. Artificial airways are essential for maintaining respiratory function in critically ill patients in the ICU. They help to deliver oxygen, remove carbon dioxide and protect the airway from obstruction or aspirations. That is, when we put an artificial airway, like for example when you put an endotracheal tube, it helps to oxygenate the patient, it helps to remove the carbon dioxide and protects the airway from obstructions and aspirations. What are the types of artificial airways? Endotracheal tube. This endotracheal tube is inserted through the mouth or nose into the trachea and it allows for ventilation. That is, once we put the endotracheal tube, we can ventilate the patient by connecting to a mechanical ventilator. Next comes the tracheostomy tube. It is inserted directly into the trachea through an incision in the neck and provides a more stable airway. That is, the tracheostomy tube is placed by doing a small surgical incision in the neck and the tube is placed into the trachea and it is said to be more stable airway. Next comes the laryngeal mask airway. This airway is placed in the pharynx to create a seal around the larynx. That is, it is less invasive. It is just providing a seal around the larynx and helps to ventilate the patient. It is less invasive than the endotracheal tube. In other airways, we have oropharyngeal airways and nasopharyngeal airways. What are the types of airways? Here we can see this is the endotracheal tube. Okay, and this endotracheal tube here we can see here we can see a connector, right? This is the connector, and to this, with this connector we can connect it to a oxygen source or to the ventilator. And this is the endotracheal tube, which is made up of PVC, that is polyvinyl chloride. And here we have a balloon through which we inflate this cuff, right? And here we have a valve. We put this air syringe full with air and we inflate the balloon and we inflate the cuff here, right? This is called the cuff. And here we have an opening, that is the bevel opening. And here at the end, at the corner, we have an eye. It is like an eye, okay? And it is called Murphy's eye. And here, why we have this eye? We have this eye because sometimes if the tube get blocked here, then the patient, the air can at least pass through these spaces and we can oxygenate and ventilate the patient through these spaces. This is why this Murphy's eye is there. Next comes the nasopharyngeal airway. Here, these are the nasopharyngeal airways. We put it through the nose, right? And when we put it when the patient is having a tongue fall. And mostly in those cases where we cannot put it through the mouth. That is when the patient is conscious or when there is some injury in the mouth, we put it sometimes through the nose to prevent tongue fall. And this is called oropharyngeal airway. This is, we put it through the mouth, okay? And this we put it when the patient is having a tongue fall, and when the patient is having a tongue fall and patient is finding difficulty to breathe, to ventilate. Putting this might help the patient to breathe or ventilate. And also when we go for intubations, when we give sedations, the patient, after sedations, most of the patients, they have tongue fall, and when we put this airway, we can easily ventilate the patients. So these are of different sizes, like 2, 3, 4, accordingly we can measure the size which we can use. By here, how we can measure the oropharyngeal airway? We can, here at the level of this end, put it at the level of your teeth, incisor teeth, okay? And then this one is at the angle of the mandible, and by putting it outside we can measure it, right? At the level of the incisor teeth, and then this is at the level of angle of mandible. And similarly the nasopharyngeal tube, here at the level of the nose nares, and then this one is at the level of the tragus of the ear. And by putting it outside we can calculate the size. These are also different size, like 6, 7, 8 different size we can put in. Male we use generally 7, 8, in female we use generally 6, 7, right? And this one is the tracheostomy tube. all of you have seen, and this is also having a cuff, balloon or valve. Okay, and this through this we put the air, we inflate the balloon. And sound the tracheostomy tube, they also have a supraglottic suction port. Okay, so that we can suck out the secretions which is accumulated around the cuff, right? And some endotracheal tube also have this. Indications for artificial airway placement. What are the indications when we put this artificial airway? First, airway obstructions. Conditions like in trauma, when there is edema in the face, or when there is tumors that blocks the airway, then we put these artificial airways. Inability to protect airway, that is when the patient is very conscious, that is very conscious, unconscious totally GCS 3 or GCS is less than 8, then in that case we have to intubate the patients. We have to protect the airway so that the patient does not aspirate. Okay, then next, the patient is having a respiratory failure. Patient is fully conscious, there is no history of trauma, edema, but patient is having respiratory failure. That is, patient is failing to respirate, failing to breathe. Okay, like in conditions like severe pneumonia, in conditions like ARDS, severe lung disease, in that case, we need to intubate the patients. We need to intubate the patients and put him on mechanical ventilations. And procedural needs, certain surgeries which need a controlled ventilation, in that case we have to intubate the patients. So these are the indications of artificial airway placement. Endotracheal tube. Adult endotracheal tube, generally males we use 8 to 8.5 millimeter internal diameter size, or in female we use 7 to 8 internal diameter size. Where the tube is placed after intubation, the tip of the tube is generally should be at the level above the carina, 2 to 3 centimeter above the carina. And how we can confirm the placement of the endotracheal tube? First, by ausculting. Auscultate the chest for breath sounds, okay, bilaterally both sides, and also see the chest rise. And you can do an x-ray to see the placement of the endotracheal tube. And lastly, EtCO2 probe, that is called end-tidal CO2 probe. This is called a gold standard actually, which confirms the exact placement of the endotracheal tube. But most of the ICUs, we don't have this EtCO2 probe. If you have this EtCO2 probe, it is better to use. Cuff pressure, maintain it between 20 to 30 millimeter mercury, and use cuff manometer and check the cuff pressure every 8 to 12 hourly. Why? You should not keep the cuff pressure less than 20 or more than 30. Why? Because if you keep the cuff pressure less than 20, the patient might aspirate. Okay, and if you keep the cuff pressure more than 30, there might be injury to the tracheal mucosa. So always maintain it between 20 to 30. What is called RSI, rapid sequence induction. This we use when we intubate a patient in ICU. That is to minimize the time of intubation and secure patent airway. What we do procedure when we intubate, pre-oxygen the patient with 100% oxygen for 3 minutes. It is oxygen the patients with 100% oxygen before intubating for 3 minutes. What are the drugs? Induction drugs what we use: either propofol, ketamine, midazolam, fentanyl. Generally in ICU we avoid propofol because using propofol it will drop the BP, and this is harmful for the patients. So generally we use etomidate, or we use ketamine when there is BP is low, or we can use midazolam and fentanyl also sometimes. Then after that we give neuromuscular blocking agents. We use choline or acronium or atracurium. And once you sedate the patient, ventilate and sedate and paralyze the patient, after that you are going to intubate. Ask somebody to apply cricoid pressure, because applying cricoid pressure prevents aspirations. And after that, insert the endotracheal tube. What is nursing concern here? Have routine intubation supplies available. That is, always check for the What are the supplies? Whether supplies are ready, available, uh, supplies for intubations are available. Check for workable suction sources and provide regular suction catheter and Yanka catheter. Check the suction source whether it is okay or not, and provide regular catheter and Yanka catheter, suction catheter and Yanka catheter. Okay. Check for medications available, and check also for patency of the IV line. Tracheostomy tube may be cuffed or uncuffed. Admin size is 7 to 8 millimeters generally and have a disposable or reusable inner cannula. And cup pressure maintain it between 20 to 30 millimeter mercury. And then we have the oropharyngeal and nasopharyngeal airway to maintain the airway patency. That is, when the patient is having tongue fall, to maintain a patent airway, we use these airways, right? Next, airway management technique. How to manage it? Do suction regularly when it is required. Remove the suctioning and maintain airway patency. Humidity. Always use a humidifier. Don't give a dry air to the patients, because this will cause blocking on the blocking of the endotracheal tube or blocking of the tracheostomy tube. So always give a humidified air to the patient. Mechanical ventilation. Using a ventilator to assist or control the patient's airway is important. And lastly, tracheostomy care. Maintain and managing a tracheostomy care is very important. Always take care of the tracheostomy wound and tracheostomy tube. Complications of artificial airway. When put an airway, it carries certain complications like injury to the larynx. It may cause injury to the trachea or bronchi during intubation or tracheostomy. Very important, very careful. Infection. When we keep a tube for endotracheal tube for a long time, this carries the risk of infection like pneumonia, tracheitis, or sinusitis due to contamination of the airway. A VAP. We have VAP when we keep the tube for a long time. There is high chances of VAP like pneumonia. And also there is chances of airway obstruction. That is, the tube might get blocked, right? The endotracheal tube or tracheostomy tube might get blocked. So it is very important to check regularly for that. Lastly, what are the best practice and guidelines? Proper training. Clinicians must be competent in airway management technique. The clinicians who is handling these patients must be competent in maintaining airways. And always follow a checklist, because it minimizes errors to a great extent. Continuous monitoring is very important. Regularly assess the airway, ventilation and oxygen status of the patients. Very important. And multidisciplinary approach. You cannot be like, oh, okay, I will do it alone. No, it is a team effort. A good collaboration between nurses and respiratory therapists and physicians improves the outcome of the patient to the great extent. With this, I would like to thank you.